jumping on. We're about to start the Planetary Health Colloquium number 2. All right. Well, why don't we get started? I want to welcome everybody to the second in a series, the Planetary Health Colloquium, which is going on this year. It's being co-sponsored by the Department of Environmental Health, as well as the Departments of Nutrition, Infectious Disease and Immunology, and Global Health and Population, as well as the University Center for the Environment and the Harvard Global Health Institute. So it's a big community coming together. And we're putting on a series of seminars about the broad topic of planetary health. The first was a sort of overall introduction with Howie Frumkin and Alan Brandt as a discussant. Today, we're incredibly lucky to have Caroline Bucky and Sana Sokolov talking about what I think is really one of the most interesting topics in planetary health, which is how our sort of disruption and changes in natural systems really focused around landscape and land use ultimately affect exposure to infectious diseases. And this sort of field of disease ecology is one of the really, really rich areas connected to planetary health. So that's going to be a huge treat. Before I introduce Caroline and Sana, I just want to let you know that the third event, each one of these will be the first Wednesday of the month. So the third event will be December 1st, also at 1 o'clock Eastern time. That event will bring together a sort of world-renowned pollinator ecologist, Lucas Garibaldi, with Matthew Smith in the Department of Environmental Health here at Harvard, who's a research scientist, and Frank Hu, who chairs the Department of Nutrition at the School of Public Health. And they'll be talking about bees as health workers, how pollinators protect human health. So we'll sort of move from infectious disease to nutrition. But today, we're incredibly lucky to have two heroes of mine and teachers of mine in Caroline and Sana speaking with us about what I think is a super, super fascinating set of topics. So Caroline is a professor of epidemiology, and she's also the associate director of the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School. Her work really focuses on understanding the mechanisms driving the spread of infectious diseases that impact the most vulnerable populations worldwide, with a particular focus on malaria. She's interested in the impact of human mobility and migration on the spread and control of pathogens. And her group uses a whole range of mathematical models, experimental and genomic data, and big data from mobile phones and satellites to understand how human mobility patterns spread pathogens and can be used to inform public health interventions. So she is spending this year at the Radcliffe Institute and working on a really neat project she's going to be telling you about. And Sana has been a teacher of mine for years. She does incredible work in West Africa. She's a vet and a PhD and a disease ecologist at Stanford, at the Woods Institute for the Environment, and also at UC Santa Barbara's Marine Science Institute. She is executive director of Stanford's new program for disease ecology, health, and the environment, and is interested in discovering and promoting ecological solutions that benefit human health and a healthy environment. As part of her research program, she also founded the Upstream Alliance, which could be a good name for the Planetary Health Alliance, a research initiative joining partners across the globe for the reduction of the parasitic disease schistosomiasis. So Sana has done some really, I think, seminal work in understanding the relationship between dams and schistosomiasis, and some incredibly creative work on ecological interventions. So hopefully she'll talk a little bit about that. But let me get out of the way and let Caroline present the work that she's been doing. And then Sana will be offering some reflections on her work in West Africa as well. So take it away, Caroline.
Thank you, Sam, and thanks so much for having me. Let me share my screen. So can everyone see that? It's all okay? So today I'm going to talk about a very specific topic that I've become interested in over the last couple of years through my work, but I should caveat this talk by saying that I'm not really going to talk about what I've done over the last kind of 11 years here at Harvard. Mostly, like Sam said, we work with mathematical models, we work using different types of data streams to understand mobility and migration and the consequences for the control of infectious disease. And, you know, the problem in Guyana, which is where I'm going to focus this talk and where I've been working for the last several years now, is, I think, an archetypal example of planetary health, because it brings into consideration so many different environmental, ecological, social, political factors that I don't have any answers here. And so I am presenting the problem as I see it. And I am interested to know from those of you who are more embedded in the kind of climate science and environment side of things, how we can move forward on this problem. I don't think that there are easy solutions. So I'm going to talk about malaria in Guyana, and I'm going to focus on the impact of gold mining. So just to orient you, the left-hand map shows the Americas, the distribution and endemicity of malaria in the Americas. The darker the red color, the more malaria there is. And you can see that we have a lot of malaria in the Amazon region here. We've had massive resurgence of malaria in Venezuela with the political collapse of the country. Guyana is here. It's tucked between Suriname, Brazil, and Venezuela. It's a small country. It has about 800,000 people. And it has one of the sort of, to a large extent, untouched. I'm going to use the word untouched. It's not really untouched, but large tracts of forest. Now, the global agenda for malaria since 2007 has been on gradual elimination, with the ultimate goal being eradication. This was a goal that was actually begun in the 50s and dropped in the 1960s due to the emergence of resistance to insecticides, as well as some financial issues. But the Gates Foundation and others have decided to put this back onto the global agenda, and that has affected country-level programs to the extent that there are now regional elimination agendas with targets for 2030 and so on. So if we look in the Americas, this graph on the right, which is from PAHO, the Pan American Health Organization, and we look at the percentage change in malaria cases over, I can't remember, you know, over the last decade or something like that. We can see there have been great strides, including elimination in Paraguay. And then up here, we see enormous growth in cases in Venezuela. Nicaragua, this is a bit misleading because the numbers are still relatively low. And here's Guyana. So we've seen malaria coming back, and we've seen an increase in malaria. So Guyana is supposed to be eliminating, and their current target is still 2030. In fact, it's 2026 for one species of malaria, falciparum, which is the more severe kind of the parasite. And I work very closely with the control program. And the things that we do with the control program are to try to optimize this cycle. So the control program receives reports from clinics and hospitals about the burden of malaria around the country. And then they have to make decisions about resource allocation and deliver those resources to the populations at risk. So malaria, unlike other types of pathogens, we have a whole suite of imperfect tools that we have to deploy depending on the context. So diagnostics and treatments are obviously the sort of first line, but there's also the delivery of bed nets that are treated with insecticide, as well as indoor residual spraying, where you spray the inside of houses, and sometimes environmental modification. On the other end, so you have these kind of distribution of commodities, and as well as, you know, things like treatment. And then the clinics and hospitals and so on, they report back data on cases and deaths, as well as reporting things like stockouts and what they might need. So my group's project is to try to optimize this process and produce better risk maps. So this is a sort of risk map on quite a coarse spatial scale of the country here in Guyana, showing that will inform how they deliver different types of resources for control. So one of the biggest problems for malaria in the context of a country like Guyana is that this is a very complex parasitic disease. It's a eukaryote, it's not a virus or a bacteria. It's transmitted by an Anopheles vector, a mosquito vector, and it has a complicated life cycle shown in this graph. So when an infectious mosquito bites somebody, there's this liver stage where the parasites develop in the liver before they burst into the blood. And this blood stage of the life cycle is where all the symptoms occur. So you have no symptoms in this part of the life cycle, and then you go on to transmit to another mosquito. So the immediate problem for me as an epidemiologist involved in surveillance is that there is about 2 weeks between being bitten by the mosquito and having symptoms. And so as we've all become very familiar with COVID-19, that incubation period, the time between infection and symptoms, becomes important for understanding the spread of the disease. Specifically, in 2 weeks, you can get pretty far before you know you're ill. So regardless of where you get infected by the mosquitoes, you might, go home for a bit, travel somewhere, you finally start feeling sick. By the time you get to the clinic, and remember, it's the clinics that are going to be reporting that data, you might be quite far from where you actually got infected. And what that means is that separating out where transmission happens from where the clinical cases are is quite challenging. And we want to allocate our resources differently. We want to have the treatment and the diagnostics at the health facilities. We want to deliver bed nets to the places where people are actually sleeping. And we want to think about exposure and vector control in the places where transmission is happening. So that's just to say that there's this general problem for epidemiologists in trying to create a risk map like the one on the left, because of human migration and mobility, it's actually quite hard to figure out where to send resources. So another problem in Guyana is that this is an incredibly remote country. So you can see this is the population density. Here we have Georgetown, the capital, and this pink area is where malaria is endemic largely. The so-called hinterland region on the border with Venezuela and Brazil. You reach there from Georgetown in a small plane, and then you have to travel by boat and then by truck and so on. And I think remoteness is always problematic for public health in general, because we have this tension that arises. And in the context of planetary health, we have a tension that arises because access to healthcare is facilitated by roads and development, and that's not necessarily aligned with some of the environmental goals that we might have. So the concrete ways that this affects surveillance, and this is the last thing I'll talk about in terms of our work, is that you get massive reporting delays. So here's just the regions of Guyana. Regions 1, 7, 8, and 9 are the endemic regions. 4 is where Georgetown is. And this graph here shows the proportion of cases that are reported within a month. So all the cases that happen in March are supposed to be reported by the end of March so that the control program can figure out what to do. But what you can see is that in region 1, for example, up on the border with Venezuela, less than a quarter of the cases have been reported within a month. Sometimes the lag is 8, 9, 10 months. So you don't really have any way of understanding what's happening in anything close to real time. So this is a kind of methodological problem that we work on. But what I want to talk about in this context is, let's just focus on region 1. What's happening with the malaria cases there? Okay, so these are familiar pictures. Gold mining is very prevalent in all of the malaria endemic regions. In fact, nearly all the malaria cases come from areas with a lot of mining. This is in Port Kaituma in region 1, and this is a mine near the Venezuelan border that we visited last time I was there. The Guyana Shield is very rich in gold. In fact, it's rich in bauxite and diamonds as well. And you can see that this impacts deforestation, and this will not be news to anyone. But Guyana has had a particularly rapid decline or a rapid increase in deforestation over the last years, even relative to other countries in the Guyana Shield. Chavez et al. Produced this paper, which I thought was interesting. So the impact of deforestation on malaria is actually not totally straightforward. This paper kind of showed that the impact is really in these small patches, less than 5 kilometers, and those are the main drivers in many parts of the Amazon. So this just shows the positive correlation in different months between the numbers of malaria cases and these little chunks of forest that are deforested over time. In the extreme, right, we just concrete over everything and malaria goes away because there's no more vectors. And so if you look at some of the modeling that goes into the eradication projections for malaria, a lot of the effects, a lot of the reason that we even think it's feasible is because the projections say that we'll concrete over so much of our forested area that malaria will go away sort of on its own. And I think that's deeply problematic when we think about the elimination agenda in general. Are we going to hitch feasibility arguments to sort of complete destruction of the environment? And is there a way that we can think in a more holistic way about this? Okay, so I drew this on my iPad. So here is a sort of schematic of the forest edge that happens with the tailing ponds from the mines, right? So these are supposed to be tailing ponds. And if we move from left to right, we're getting sort of increasingly deforested and degraded. But when you first make gold mines in these areas, you get these tailing ponds that have a lot of contaminants. And what happens ecologically is that you get anopheles on the forest edge. So these are forest edge species, things like Anopheles darlingi, and they hang out at the edge of the forest, which is why these small patches of deforestation are so important for malaria transmission, because you basically increase the surface area of the forest edges. You also get sandflies. So sandflies emerge in these tailing ponds as well. And then ultimately we've seen as well Aedes, which is the dengue vector, can spread dengue and chikungunya and so on. So in these forest ecologies, you actually get this kind of spectrum of vector habitats. And so if you think about the diseases that these bugs spread, Anopheles is the malaria vector, sandflies spread leishmaniasis, and Aedes spread dengue. If you ask miners what their main complaints are when they report illness, gold miners, this is in French Guyana, I believe, the top 3 are malaria, leishmaniasis, dengue, and chikungunya. So you have the gold mine itself creating habitats that encourage particular kinds of vectors that bring with them the possibility of transmission of different infectious diseases. And from the perspective of the vector control unit in Georgetown, their job is to try to understand how to both provide healthcare to the miners, but also tackle vector control and think about these more broad environmental health issues. So in fact, we just published this paper in Lancet Planetary Health. The gold price, the international gold price, is actually strongly predictive of malaria cases in Guyana, to the point where you could use it to forecast. And so we've been working on trying to understand how you would implement that in real terms. But one thing I want to talk about here, and I will come to an end in a minute. If you look at the age and sex distribution of malaria cases in Guyana, what you will see is that, hold on, I want to go back. So what you will see is that it's massively skewed towards men between the ages of 15 and 60. So basically these are minors. And when we took the malaria cases and we just crudely separated them into men age 15 to 60 or 50 and everyone else, and then looked at the correlation with gold price, what you can see is that there's a very, very strong correlation between the number of monthly malaria cases and the adjusted gold price in that demographic. And so it's not it's quite a crude separation, but it captures this issue, which is that gold miners are largely young and able-bodied men, and they go into the forest and they mine opportunistically, sometimes seasonally, and they get malaria. And then what's interesting is that if you look at the time lag associated with these two groups of people, there's a sort of a couple months lag before indigenous communities, more stable communities, and women and children and older people get malaria in terms of the time series. Right, so here's the two groups there. So the other reason that Guyana is interesting is because it's the second it's only the second place in the world where we've seen the independent emergence of drug resistance to our last frontline drug against severe malaria, which is the artemisinin. And so we have found mutations associated with resistance, and there has been some hint phenotypically, so it's actually clinical hints that there might be resistance. And it's not clear exactly what's driving that, but one of the strong hypotheses is that, you know, the mining community is largely using the black market or private means to buy their drugs, and those drugs are not good quality, and so they're promoting the emergence of resistance. And so the government generally feels that drug resistance is spread by migration, and it's miners that are doing so, which is reasonable enough. Okay, so that's malaria. And an additional and sort of more planetary health focus, and this is something that many of you are going to know much more than I do, is that the gold mining process uses mercury. So here's some miners here sort of washing away the topsoil. It gets sucked up. And then they have these sluice methods where they add mercury at this point. So mercury goes into the water here. And then when they burn off the mercury during the amalgam process, so they basically mix their gold into the mercury, they form an amalgam, and then they burn everything off, and they're left with pure gold that they can trade. But what that means is that they're breathing in elemental mercury. So obviously that has all kinds of health issues for this community, for the miners in general, and for the people that are involved in different stages of the mining process, as well as the addition of mercury in the water. So then communities that are affected by or eat fish from water that's contaminated and so on, all of those problems emerge. There is mixed evidence for the relationship between malaria and mercury poisoning in terms of increased susceptibility. And I'm happy to talk about that. I think a lot of it is correlational, but by necessity. But there is some sense that mercury impacts immunity, and that can be bad for your susceptibility to infectious disease as well. So this is just from excuse the horrendously ugly bar charts, but this is from the Minamata initial assessment report for Guyana. This is about the Minamata, it's obviously about mercury. And so this is in Guyana, what you can see, these green bars represent the release of mercury into the air and to the water from gold extraction with mercury amalgamation. That's that process I showed you that the miners are using. And so far and away, this is the most important source of the release of mercury into the water, into the air in Guyana, even compared to more industrial level mining and other things. So I think from an environmental perspective, there's also major implications of this activity. Yeah, and again, this is obviously a massive problem, but possibly there are also opportunities to kind of merge some of these agendas, the public health agenda, try and think about how we could pair that and provide financing and a more holistic approach to dealing with some of these intersecting problems. So I'll just finish here. And I just drew a little diagram here where my sort of schematic of how things are connected. So the international gold price, which is going from strength to strength amid global political and economic turbulence, drives gold mining in a very clear way in Guyana. And that leads to deforestation, increased mercury use, and that creates anopheles habitat. Of course, rainfall plays a role there too. And those things bring labor migration, what's called pendulum migration. So miners go from their homes, they go to Georgetown, they go to the mines and come back. Though the malaria that is generated by that activity has important knock-on effects for indigenous communities, some of whom are involved in mining, but not all, as well as refugees. So Guyana has accepted a lot of Venezuelan migrants across the border into these hinterland regions. And they are also impacted by this. So I would just end and open it up for discussion by saying that health systems are designed for static populations. The way we count things, the way we assess burden, the way we think about resource allocation, it's all designed around using a census denominator, right? We use a census to define where our populations are. It doesn't work in these highly mobile systems where people are constantly on the move and many are illegal in inverted commas. I think that there is this remoteness issue that creates tension, not just in Guyana, but everywhere, where the environmental priorities may be to keep places so-called remote. The social priorities might be to push for development. And I think that's going to create political tensions that we just have to think about in a better way. Gold mining is a key source of livelihood for the most vulnerable. In Guyana, they've taken a different approach policy-wise, where they've let it out to small-scale Guyanese miners explicitly, kind of not bringing in outside corporate interests. And you're not going to get rid of that. That it's true worldwide. And so my feeling, and I'd be happy to discuss this, is that the way that we think about science in my field is not sufficiently holistic. I really believe that if we don't think about these drivers that are social, that are political, that are economic, that are environmental, we will never, the elimination agenda is just a fantasy. So I think we have to seriously start thinking about these migrant populations and their environmental impacts and what we can do about it to help them and to prevent the destruction of some of our great forests. So I will stop and pass it to you, Sana.
Carolyn, I'm just going to jump in really quickly. Thank you so much. And I can't imagine a better person to just reflect a little bit on the same chain of sort of livelihoods driving land use change, driving changes in infectious disease exposure, and no better place that I can think of in the world in terms of that sort of holistic thinking that you're talking about. So it's a great setup, Sana, if you talk a little bit about what you've been doing in West Africa, and then maybe we can see if there are any ways to connect the threads here.
Thanks, Sam. Thanks, Caroline. And thank you to the audience. I just have a few minutes, and I was asked to just reflect on some of my experiences. I am not going to use slides, just going to talk and tell you guys a few stories about, where I've been working, what I've seen, and how that might tie into what we just heard from Caroline. So a little over a decade ago, I found myself on a plane to the far corners of the world in West Africa, in Senegal, in the westernmost tip of West Africa. And both literally and figuratively, I dove in the deep end of parasite-infested waters there. Unbeknownst to where that would lead me, actually, as a young budding postdoc, just having minted my PhD. Just to give you a little bit of the backstory about why these waters there are so parasite infested, it wasn't always the case. Since about the 1990s, this parasite schistosomiasis, a blood fluke, a worm parasite, has really, really exploded in numbers in this region. So before the 1990s, where was it? What was going on? And some of our work has uncovered, as well as work of many giants on whose shoulders I stand in terms of studying this region, that it was really the building of a dam on the Senegal River. Senegal River is a really large river basin being fed by 4 countries in West Africa and leading out to the mouth in the northern portion of Senegal in the Atlantic Ocean. And the dam was built about 25 kilometers upstream of the mouth of the river. In other words, many hundreds, thousands of kilometers of river were essentially blocked to the previous both saltwater intrusion and flows up and down of natural migratory fish. And, in my case, we'll hear a little bit about a crustacean. And also, these waters were historically inhabited by this snail. So it's not a mosquito, but it's a similar tiny animal that carries schistosomiasis, carries the parasite. So we all, like Caroline, studied satellite imagery. We did models and we looked at this region, and it's really obvious from space the massive changes to the ecology of the region from the dam. But what people hadn't realized until our teams really got boots literally underwater and really came to ground level was the extent of the decimation of the natural inhabitants of these rivers. that probably historically preyed on the snails. And so this piece of the puzzle was something that emerged from our research. And kind of to make a long story short, it wasn't just the loss of these predators, but as in Caroline's case, it's a very complex social and ecological system where dams are built, migrants come in to not only build and work on the dams, but also the agriculture they support. And so you have this sort of perfect storm of sort of decreased predators of the snails, increased habitat for the snails, more people, living conditions, without great sanitation because the migrations happened rapidly and the expansion happened rapidly. So what's kind of unique about our work is that we didn't stop there at all. We really dove right in also to understanding the interlinkages of all these systems and thinking about solutions. So one solution that wasn't so obvious when we started, but seems really clear now, is the restoration of some of these species that were decimated. These species like a crustacean, a large freshwater prawn that used to migrate up and down hundreds to thousands of kilometers up and down this river system. And in 2015, we did publish a study that demonstrated when we restored these prawns to water access points where villagers were getting schistosomiasis, infection rates were far decreased, about 50% decrease in the reinfection rates in people, 80% decline in the snails carrying the parasite. So the predators have a really big role in reshaping the system. And so there are many, many possible ways that we have been looking into to restore the ecosystem, both for the inhabitants themselves, the biodiversity, and all of those goals, that while at the same time supporting human health in the region by decreasing this environmental rain, this environmental continuous exposure of schistosomiasis. And the reality is that, this is complicated. We haven't necessarily gotten a silver bullet, but certainly the situation in Senegal with the decimation of the river migrations and the increase of snails and schistosomiasis is not unique to West Africa. We've also been looking in Brazil, and certainly there's been studies in the Asian forms of schistosomiasis that have demonstrated a link with dam building. So some solutions are to potentially introduce aquaculture of these native prawns or other species that eat snails, which we are looking actively into, which is a fun project because it's a win-win-win. Essentially, if we can bring small-scale aquaculture into the mix successfully, we can restore some of these lost predators, but we also create a great protein source. We also can essentially improve livelihoods because these guys are valuable on markets. Some of the crustaceans we study are on par with lobsters and crabs in the market, and so they're a really great source of income. I just also want to touch one last 30 seconds on some systems we've been looking at in other parts of the world to say that restoring environments is definitely understudied as a tool in public health to improve human health. It's been ways that my work has, we're very much in our infancy there. But one thing we have to remember as well is that people who are unhealthy, who do not have access to healthcare, who do not have access to sanitation and basic well-being services like that, cannot be faulted for being driven to some of these activities that are these land use change activities that are then biting themselves back in the foot there in terms of increasing infectious disease. And one interesting solution we've been exploring with a group of nonprofits, for example, in Borneo in Indonesia, is that simply bringing health care to the remotest regions of the world where this deforestation is happening, where this land use change is happening due to constrained livelihoods, to constrained access, has actually decreased deforestation in the region of some of these interventions, these health interventions, these public health interventions by 90% or more over the last decade. So our work has definitely shown us that both restoring ecosystems can be a win for human health, but also bringing public health to these remote areas can be an incredible tool to reduce some of the extractive activities that people are relying on to simply pay for healthcare for their families, for the, to support basic livelihoods. That's all I'm going to say about that. I would love to open up to your questions about, what we do and don't know about these systems, and the types of solutions we might come up with if we're creative, if we put our heads together. I work really closely with social scientists, engineers, all different kinds of, science that, it was way outside my comfort zone when I started, because I'm really committed, and I think we all should be really committed to having, to upholding this vision of a future where both the planet and the people that inhabit it, can thrive. And to do that, we do have to think outside our little boxes, our little silos. And it's challenging, but it's very rewarding. So I'd love to hear your ideas and pass it over to the questions.
I wonder if we could start. Thank you, Sana. That's there's so many really interesting threads here, but I wonder if we could start just with a comment from Caroline as she hears about your work. I'd love to be a fly on the wall of a conversation between the two of you, because there's so many threads in common around, there's a reason that these dams were built, right? It wasn't just for the fun of it. It was to provide water for agriculture or to provide clean sources of power. So there are upsides, but then there clearly are big downsides. And then changing habitat for vectors leading to infectious disease. And both stories have a sort of aquatic nutritional dimension. Yours is a positive one, this new source of protein in diets that could really have a major health benefit. For Caroline, consuming aquatic, wildlife actually turns out to be a real problem because of the neurocognitive impacts, because of the mercury poisoning. But anyway, Caroline, I'm curious how you hear all of that story with your background.
Yeah, I think it's, fascinating work, and I think that it's a challenge for all of us how we move beyond specific cases to global policy, and maybe you can't, right? Maybe we're too quick to try to scale everywhere, and in fact you always need local solutions that are community driven. And I think that's Sana's case studies kind of speak to that, right? Which is you have to understand the specifics of that place in order to be able to design solutions that are that have their origin in the realities for people there. And I think that in global health in general, we are too late coming to some of that realization. I don't think that message has yet got to the powers that be in Geneva, for example, right? We're still making the global burden of blah, blah type models, right? Which maybe it's helpful for advocacy on some level, but I think for both of our sort of stories here, the key is that you do actually have to understand the human environment interaction, and why people are there in the first place, and what they're doing, and what they actually need. I think one difference between I'd be interested to ask, actually, because I think one of the things that I've run into is that the migrant miners who travel all over the Amazon region, actually, and this is not just in Latin America, this happens in lots of parts of the world as well. We run into this in South and Southeast Asia too. But because they're mobile, they are not particularly invested in the environment that they're in at that moment, because they're transient. And so not only are they difficult to capture in the health system because they're transient and sometimes they don't want to touch official systems for lots of reasons. So they're hard to capture in the health system, they're hard to get data on. And also inherently programs that think about environmental restoration are going to be challenging among migratory populations. My concern is that with some of the climate issues in the future, we're going to get more and more internal displacement, migratory behaviors, and international displacement as well. So how do we think about community investment in particular places for restoration projects? I think that's a big a big challenge. And I'd be interested to hear what, whether you have ideas about that, Sana, or how you think about that problem in the context of coming up with local solutions.
Yeah, that's a great challenge. Sort of bringing the voice of the marginalized communities and the underrepresented in that global stage communities who actually have deep knowledge about these ecological systems, probably long before I landed there and put my feet in the water. In fact, we rely on a lot of that local fisherman knowledge, which has been proven really in biology to have quite high correlation to biologists' data. And so the local knowledge and getting that really integrated into the solutions is just an imperative. I think a lot of the ecological and conservation organizations are really starting to wake up and realize that and wake up to that. I think in order for the public health sphere to really buy into some of these more holistic solutions, we do have to unravel the mystery in more individual case studies. In other words, we need to dig in a little bit more with the assumption that the ecological changes are profound enough to be causing a large burden of the burden of disease that we're seeing. And when we can absorb that, then we have to unravel what it is precisely about the environment that we have agency over, that we could alter, and we need to get very creative about that. And I think bringing in other ways of knowing and local knowledge and indigenous voices and the communities themselves who live in the remaining places that we're trying to preserve, or help those communities live as great stewards and live well, with very high well-being themselves. And it's a great challenge, but it's actually not that it's not that rocket science in some ways. We do have to just get out there with our feet on the ground, talking to people, looking at the biology, and it's very complex, but we call them little ecological levers in there. We need to find those, and I think modeling has a role in this too. We need to find those areas, again, that we have agency, but also have a big ripple effect on the disease burdens. And once we find those and we have, data and evidence to show those links, I think the public health community will buy in more that those are the places that we have agency. Those are the places we could partner with other agencies involved in, for example, conservation or livelihoods or agriculture, where we could do things a little bit differently and really have a profound impact on public health. And right now, I think the mantra is that public health for public health's sake is a little bit more of the focus, a little bit less on that. So that's the challenge that we have.
Yeah, I mean, I think one thing that I've noticed, so you say that, that like, obviously we need to just involve the community. I don't think that that's obvious to a lot of the large global health funding and donor agencies. And so I think that it sounds simple, but it's not simple. And so I think that there needs to be more push for that. And one of the aspects that I think is particularly, people have a blind spot about this, is around technology. So I think that with the organizations like the Gates Foundation, they tend to have a mindset where technology is going to fix this somehow, right? We're going to fix it with tech. Tech is developed in Silicon Valley or somewhere, and then we're going to take the tech to around the world, and everything will get better. And of course, there is some sense that, like, better diagnostics can be developed wherever. But I actually think that there's a huge role for tech development that starts in the community. And I think one of the most exciting areas that is not currently thought about enough is how we start that sort of technological rollout and the idea generation at the community level as well. I think that's something that seems to be missing from the kind of broad global health funding structures and how things happen. And so I would love more integration of kind of the big power structures and the big flows of money, and the kind of community-driven, more holistic ecological community, because I think it's there and it's growing, but it's frustrating. Sometimes it's still it's sort of seen as a peripheral, you know, it's like the side seminar is like, oh, and also environment, right? If you look at the ASTMH, which is the big tropical medicine meeting, the vast majority of things are not really, the vast majority of talks and seminars and things are not here in this space. They're about immunology or, you know, these other, you know, sort of new solutions in omics and things like that. So yeah, I agree with you. I think that there's a long way to go.
There are quite a few questions from the audience, so I just wanted to dive in, and it'll bring us a little bit back into the details of the systems. Some early questions about the increase in malaria and the gold mining itself. So question about whether the increase in malaria is a consequence also of just better diagnosis and surveillance. And also some folks wondering about the gold mining itself, like where does it go? To jewelry, to electronics, like where's the demand coming from?
Yeah, so when I started looking into this, a huge fraction of demand is actually jewelry, and a lot of it goes to India and China. So jewelry is the biggest single chunk. Electronics is something like 10%, I think. And then I can't remember what the rest is. The thing about gold is that it's because it's pure, right? And so it's very easy to get a fair price for it. Even if you have a small lump that you found in your river, you can go and get pretty much market price because at the gold trader. So there's far fewer middlemen than there might be with other kinds of mining, which is why it appeals to kind of small scale and artisanal miners. As far as the malaria goes, yeah, there's always this problem of, you know, finding cases when you start looking for them in earnest. I think that was part of it in the past, but it's no longer the case because there has been a push for diagnostics and surveillance, and it's been pretty good in Guyana for the last like 8 or 9 years. Where I don't think this is a surveillance issue. This is a genuine dynamics, and so yeah, so I think it's real, and the extent to which, so I mean, they were supposed to, they just revised their elimination targets, and I should point out that the elimination targets at the moment are really for falciparum, not vivax. So most malaria in the Amazon is Plasmodium vivax, which is a different parasite species. Plasmodium falciparum tends to be associated with epidemic malaria and like frontier malaria, kind of as people push into the forest, whereas vivax is much more endemic. But I think the numbers they may not be perfect, and certainly we've got these issues with reporting lags and so on, but the trends are real.
Great. There's actually also another practical question about getting in. So it kind of touches back on, you know, my last comment too about how if we can get to these remote regions and bring healthcare and you know, livelihood support, you know, maybe some of the behaviors that we're worried about in terms of gold mining could be reduced. But there's a Médecins Sans Frontières worker asking about safety, about accessibility. Is this even realistic? You know, what's the security like in Guyana?
So there is actually there has been a concerted push to try and get diagnostics and treatments to miners. So there's this project called Malaria, where there are these kind of specific packs that they take out to miners and they distribute, and they have diagnostics and treatment to try and encourage the use of good drugs and get people treated when they can because of this remoteness issue. Similarly, in Guyana, they have a specific miners outreach part of their surveillance where they go and they do active case detection. The security is definitely an issue, particularly in some places. It's a little bit Wild West. The malaria program tends to actually, I think this is one of the most amazing things about working in malaria. You have access because the miners know what malaria is. They have very high knowledge of how it's transmitted and things like that. So they actually welcome the malaria program in because they want better treatment, because they want to be able to work. So they won't be able to mine if they have malaria. They know that. They want good treatment. So generally speaking, they have a good relationship with the malaria control program, which provides access for other things as well, right? Like once you can have trust with the mining community and indeed train miners to be able to diagnose and treat and so on, you can start to build up a network of trusted individuals who can deliver other kinds of messaging around, you know, sex trafficking, what to look for, HIV awareness, all of these kinds of things. So there are security issues for sure. I think the malaria program is somewhat protected because miners are very interested in preserving their health so that they can mine.
There are several questions and comments about the sort of bottom-up versus top-down or community participatory approach. One involves about what about the corporate and policy drivers that push the levers of increased deforestation and gold mining? What is the role of public global health at that higher level?
So I'm not an expert in this, but I will give you what my opinion is from my vantage point. So unlike other countries, Guyana had an explicit policy where they were going to give tracts of land to small scale and medium scale Guyanese miners to try to avoid this, the resource trap or whatever it's called, right? Where big corporations come in and then it doesn't benefit most of the country. So they had an explicit policy of that, which is quite different from other countries. So in Guyana, 75%, I think, of the gold is like small scale production by Guyanese, local Guyanese miners. So in that sense, it's a slightly different landscape than in other parts of the world. There are large corporations that do mine, and recently there was a large acquisition. What tends to happen is that the big companies do much better because they provide air-conditioned accommodations and they treat people, and they often just have their own like little public health system for miners that work for the big corporations. And some of those companies also get involved with the broader surveillance, although I think that there could be much more of that. Like, I think corporations that have mines in these areas should be forced to report data, to provide treatment in the local region. Because what happens is the big mining companies go in, and then the smaller miners use the roads and the access to the forest to sort of deforest around. And you get this kind of waves of people. So places that have already been deforested and mined, you'll continue to get, you know, teams of 2 or 3 or 10 people coming in with like a hose and trying to get some more gold out of the land. So that's kind of the landscape in Guyana for the different size mines and companies. The policy levers, I think, I'm not sure. I think that like you were saying, Sana, earlier, I think if we can really convincingly draw mechanistic links between some of these things, we could do a lot better job of advocacy around policy. At the moment, a lot of it is associative and correlational, and we haven't got the kind of like very clear mechanistic link that we could use to make strong claims around the impacts of mining on health. But I think but with more work, I think that could be made. And then maybe you could bring together some of the extractive industry policy and the Minamata Convention with some of the global health goals and the elimination targets. I mean, it seems to me that there's at least funding at that point for trying to think in a really ambitious way about how we deal with health among this group. At the moment, they're pretty neglected.
That's so interesting. I just wanted to also add, essentially, with this idea of there is also a question in the chat about this idea of understanding the attributable risk, or how much of the disease is attributable to some of these drivers. You know, I just want to add that I think it's definitely understanding the systems and the mechanisms. It's more than that, though. It's also you know, it's even more than observing and modeling the systems. It's actually having the boldness to do actions, to turn that into actions that you think might work, and measuring the outcomes, like we did with restoring the prawns and measuring the reductions in transmission. You know, before that, you know, nobody would have believed any of the models or the observational data was that correlated. Same with the healthcare delivery in the Indonesian context I was telling you about, leading to, from satellite independent analyses, 90% reductions in deforestation nearby after those interventions. And of course, these are individual case studies, but if we can be bold enough to take these kinds of actions and study them in that level of granularity and replicate them around the world, and they do end up emerging as powerful levers, that's when I think the global health community will get on board. So anyways, I just wanted to add that because there was quite a few questions about that. And I think
just important. On that, I think the other thing is to shift this narrative. So there has been traditionally a narrative that like, oh, well, miners have to go in the forest where there is malaria. That's not what's happening here, right? Mining creates conditions where there is malaria. So it's trying to reverse the sort of causal links in people's in policymakers' minds as well is important.
Mm-hmm.
I want to jump in here for a second, Sana, just because we only have about 3 minutes left, and it's an incredibly rich conversation, and I know there are even more questions that we haven't gotten to. I think this big picture is so fascinating. I mean, it reminds me also of Kinnari Webb's work in Indonesia with Health and Harmony, where there's been this sort of what she calls radical listening and really focusing on getting into communities and understanding what's driving ecological destruction. And as you say, by providing health services, often pulling away some of the driver and really reducing deforestation and addressing livelihoods. So in every instance, it almost seems like there's sort of the need for an optimization exercise where you've got, people, you've got a place, you've got health needs, and you're really trying to figure out what's a better way to meet those needs while protecting that environment in a sustainable fashion. And so it is that much more holistic approach. I also think there's a justice dimension that you both have sort of been speaking to, but maybe not completely directly, which is that in both these instances, there's an environmental disruption that benefits, a handful of people. In the case of a dam, it benefits a lot of people with water or clean power, and it harms other people. And often the reason that takes place is because the people who are being harmed don't really have a very clear voice. And so sometimes it's the mapping out of the power relationships that can be really important in thinking about, I think, how to address the problem. And I think land titling is probably a really interesting question in Guyana. We haven't gotten into that, but clearly if you had title to this land, then filling it up with mercury and destroying the ecosystem might not be the most effective way to make a livelihood. Whereas if you're just moving through, maybe it is. And so there's some structural things that one could think about. But in both instances, it's the downstream villagers, indigenous communities, whoever it is that are eating the mercury-laden fish that are really paying the costs. And similarly in the schistosomiasis story. So I don't know, I know we have to wrap up, but if either of you have any last sort of 1-minute reflections on any of those topics.
I can start and I'll let Sana close. I agree with you, Sam. I guess maybe I'm too young to be cynical, but I'm pretty cynical about how we use arguments of justice, apart from the fact that that clearly underlies what we're trying to achieve. I tend to think in just very concrete terms about like what will actually, what are the levers that we can pull, and the land titling is a great point, and I think that that's something. It's a very challenging topic in itself that we could talk about for an hour, but certainly trying to find ways to help people feel invested in their environment is would be helpful. But I think that you're absolutely right. This does come down to an underpinning philosophy, which is like everybody's the same, and everyone has the same right to, health. And so you can't start to do these large projects that end up hurting and harming and causing disease among large fractions of the population just because they're poor or vulnerable or otherwise don't have a voice. I don't know I don't know how to bring that into the science. And maybe other people know more in either legally or in a social science sense. And I would be very interested to hear from anyone that has concrete ideas about how to do that. And then the last thing I would say is that if anybody would like to talk more about this specific issue, I am open to talk about this for as long as anyone has patience for it. So yeah, very, very happy to discuss further.
I think we're out of time. Should I just thank everyone?
Sorry.
It's okay. I guess I'll just say in 10 seconds that I'm very actively involved in Stanford's growth in this direction in terms of building out bridges between the medical school and their sustainability initiatives. And I think in addition to sort of trying to dive into the details and solve these problems like we're trying to do in partnership, in fact, with the leadership and guidance of the local communities who know it even better than we do. We also need to think about restructuring the way we train scientists in general and how we build these bridges in their training, and so that we can sort of have a next generation that really is equipped to deal with these complex systems in a way that we've all kind of carved paths on our own and struggled through. But I think that is a no-brainer next step for sure. So it's the next generations that are really going to save us.
Well, thank you, Sana. That's a great point. And just a reminder that our next Planetary Health Colloquium talk will be in a month on December 1st at 1 o'clock, and we'll focus on bees and nutrition. And we hope to see all of you there. And huge, huge, huge thanks to Caroline and Sana for sharing this incredibly interesting work with us. So great to be with you.
Thanks for the invitation. Thanks for your attention, everybody. Bye.
Bye.